Hello everybody, I'm Dr. Bhavana Singla, Senior IVF Consultant from Advanced Fertility and Gynaecology Center, New Delhi, India. Today, first of all, I wanted to thank the International Academic Excellence Award for giving me the Best Researcher Award of 2024 for my work. Today, I'm going to share my work in this presentation, that is the role of anti-tubercular treatment in vitro fertilization, that is IVF. Female genital tuberculosis in the female genital tract infection is the caused by the Mycobacterium tuberculosis, and it is an important cause of infertility. In 90% cases, it affects the fallopian tubes, causing the tubal blockage, hydrosalpinx, or the pyosalpinx tuber-ovarian masses. In 70% cases, it affects the uterus lining, causing the cavity distortion, intrauterine adhesions, resulting in recurrent implantation failures or the recurrent miscarriages. In 25% cases, ovaries are affected, causing adhesions or the tuber-ovarian masses. In some cases, the cervix, vagina, or vulva can be affected. Symptoms are usually irregular periods, chronic pelvic pain, or the infertility causing the recurrent implantation failure or the recurrent miscarriages. For diagnosis, clinical history, and the clinical examination are very important, along with the transvaginal ultrasound and the other invasive procedures like laparoscopy, hysteroscopy, endometrial biopsies for cultures, polymerase chain reaction. In invasive procedures, operative surgeries can be done together like adhesiolysis, hydrosalpinx drainage with tubal clipping, tubal cannulations, etc. Along with all these procedures, clinical suspicion plays the most important role in diagnosis. There is a very important tool called the CRS, that is Composite Reference Standard, in which if the various investigations like AFB cultures, endometrial or peritoneal biopsies, or the laparoscopy or hysteroscopy, if they are not showing the definite findings of female genital tuberculosis, on the high level of clinical suspicion of previous history of tuberculosis, pulmonary or extrapulmonary tuberculosis, obstetric history, infertility history, repeated IVF failures, thin endometrium lining, the suspicion of the female genital tuberculosis can be made and treatment can be started accordingly. In our study, we are evaluating the role of anti-tubercular treatment in vitro fertilization, which is a retrospective analysis. We have studied the 45 infertility patients in 4-year duration in the age group of 23 to 35 years, with the inclusion criteria of cases of thin endometrium in which the lining was less than 7 millimeter in the natural regular cycles or the between in the medicated cycle between day 13 to day 20, or if there is a repeated IVF failure cases more than 3, or recurrent miscarriages more than 3 without the other obvious reasons, or if there is any history of hysteroscopic or laparoscopic adhesions, these are also included in our studies. In all cases, the pre-IVF hysteroscopy was done with the endometrial biopsy for the tuberculosis PCR. Only in 2 cases the TB PCR was positive. In rest of the cases the TB PCR was negative. But in all cases, on the as per the inclusion criteria, we have started the anti-tubercular treatment. First, we have started with the AKT4, that is the combination of 4 drugs, rifampicin, isoniazid, ethambutol, and the pyrazinamide for 2 months, and then they were shifted to the AKT2 treatment, that was the combination of isoniazid and the rifampicin. In all cases, the fertility treatment was started after the 2 months of AKT4 treatment. In all cases, the frozen embryo transfer was planned. The medications were given as a estradiol valerate from 6 to 8 milligram in divided doses, followed by the transvaginal sonography for endometrial thickness. When the thickness was more than 8 millimeter, the embryo transfer was planned in all cases. Efficacy of anti-tubercular treatment was assessed by assessing the endometrial thickness just before the endometrial transfer, pregnancy rates, and the clinical pregnancy rates. In our cases, we have included the 23 to 35 years age group. In all cases, there was no difference regarding the demographic variables, egg reserve, sperm parameters, number of embryos transferred, or the embryo qualities. We have included the cases of thin endometrium, previous history of thin endometrium, previous multiple IVF failures, recurrent miscarriages, and the history of laparoscopic or hysteroscopic acidolysis. Out of 45 patients, 31 patients were positive. That was the 68.8% was the pregnancy rate. But in 2 cases, the heartbeat didn't came at 6 weeks. So the clinical pregnancy rate was 64.4%. As we know, the female genital tract infection, it is important for implantation of embryo in endometrium. The earlier study stated that the genital tuberculosis produces extensive damage to the uterus lining and the fallopian tubes, leading to recurrent implantation failures. Significant alteration in the endometrial tissue metabolites, largely related to energy metabolism and the amino acid biosynthesis, and the imbalance of these endometrial receptive marker lead to the recurrent implantation failure. Female genital tract tuberculosis alters the cytokine levels in endometrium with increased prevalence of interferon gamma and the tumor necrosis factor alpha in endometrial tissue and aspirate in TB positive cases, which may lead to the implantation failure or the recurrent miscarriages. In our study, on the strong clinical suspicion and on the basis of CRS, we started the anti-tubercular treatment in all 45 females with the AKT4 in the first 2 months, which included the rifampicin, isoniazid, pyrazinamide, and ethambutol, followed by the 2 months of followed by the 4 months treatment of AKT2, that was rifampicin and isoniazid. Fertility treatment was started in all the females after the 2 months of AKT4. So we concluded that there is a great role of anti-tubercular treatment in infertility in cases of thin endometrium which were not responding to medications, repeated IVF failure, recurrent miscarriages, and the previous history of hysteroscopic or laparoscopic acidolysis. And it definitely improved the endometrial thickness, pregnancy rate, and the clinical pregnancy rate. But definitely we need the further well-designed studies required to predict the pregnancy rate and the clinical pregnancy rate more precisely with big sample sizes. Thank you.